One of the overriding elements of the journey I've been on is to absolutely echo your views that at the moment we haven't won that battle between what's at the top of the boardroom, what's at the top of the executive team, what's at the top of the clinical directorate management team with regard to the most important element. We've got an undoubted wealth of evidence to suggest how you can save money, you can improve the delivery of a balanced budget through doing things the right way at the right time in the right manner. But we haven't had that persuasive argument put in place. And for me, a salutary experience was when we knew what to do, and Andy mentioned it, we knew what to do with regard to VTE to try and reduce the harm that was causing, not just in terms of reduction of deaths, but the long period of harms that people have after VTE events that they pick up in hospital because of the care we do. We knew what to do. Every doctor, every nurse, every pharmacist knew that there was a way through this, but we didn't introduce a risk assessment process at scale, and we didn't do it because it was just another exercise to do. And so we were trolling around about the sort of the low 20s, in some parts of the country less than 20%, even though this had been out for 3 or 4 years. And it took a financial incentive, it took a sequin to really galvanize the interest from directors of finance, from the financial elements within trusts, to see that this was the right thing to do. And that seems to me a tragedy, that it took a sequin to do this. But what it did do was to move, on average at that time, about 40% of the country doing risk assessments for the millions of patients that come through the doors of hospitals each year, up to 90%. And it did it within 6 months. So that small payment, now that small payment was supposed to go to help support the VTE teams around the country. And many of you know that's probably what didn't happen. That money probably went into some baseline support for our trusts. But what it did do was to elevate the conversation that took place within trusts. It then demonstrated, we were told, well, you've hit the 90% now, Mike, so I think we'll stop the sequin payment. And for those of you who will go to Francis' session later on, and those of you who are working hard on improvement methodologies and science will know that 90% doesn't mean squat. So the choice was to increase the goal and move the goal up to 95% or higher. And so we managed to save that sequin payment for another year. And yes, then the NHS responded to that. So and now we're up at the 97, 98s, and in many trusts greater than that. But it's taken 3 years for us to then start to have the peer-reviewed articles now that are demonstrating at scale that harm from VTE is reducing, deaths from VTE are reducing, and that's not just in small-scale hospital studies, it's in large-scale national studies. So that starts to win the argument. But I think for me, there's a more fundamental issue, and that's if one of the heroes for me in this work is a man called Avedis Donabadian, who many of you will have read his work, and he talks about the elements that Andy brings out in his paper in terms of his whole treatise was on structure, process, and outcome, and delivering that at scale, both in an educational perspective, but also in terms of research and quality improvement. But towards the end of his life, he also recognized that it was much more to that in terms of sustainable improvement, and sustainable improvement where we meet our patients, that treasured opportunity that we have when we talk and listen to our patients, who are the best signal of when things are going wrong for themselves, otherwise they wouldn't be coming to us in the first place for support. And he recognized that it was the ethical principles of the individuals who are part of that system that was the most important element and a key element. And for those of you who've read his work will remember that he talks about And of those ethical principles, it's that principle of love that is absolutely key to bring about sustainable change, whether that's at small scale or large scale in terms of a national process. And we shouldn't underestimate that, and we shouldn't undermine that element of love being absolutely crucial. Crucial for you to support your patient, but also crucial for you to support your staff and your organisation, as well as at a national level. And just so you think I haven't lost the plot completely, the other element for me is another guy called Codman. Many of you would have read his work at the beginning of the last century, where he struggled to introduce the concept that actually the answers to a lot of questions about improvement and improvement of care were in the records, the case notes, the records that we keep of our patients' journeys. And he struggled to have that as a concept that was really important in Boston at the time. But he won through the day, and he produced a template from which we now are learning 100 years later. So one of the other elements for me in terms of design and in terms of delivery and in terms of data is how we use our case notes. How do we really use our records to understand why things have gone wrong and how we can improve on those elements. And many of you will have read Nick Black's work and Helen Hogan, and Francis was a key author of that first PRISM 1 study. And PRISM 2 is just about to come out, which will highlight that degree of deaths that occurred due to problems in care. And the lessons are salutary again. So we know we have a system, we know we have a design mechanism in their place, so I think we should use this and use those elements to support the business case. One last piece before I hand over to Helen, and that's that you've heard a lot about from Virginia Mason in terms of litigation costs falling as they've been on their improvement journey. They're not an isolated system. They're a small hospital, but you have to go to Michigan, you have to go to Massachusetts. The same stories are there, where the payers, the commissioners in terms of our language, their payers, work very closely with the legal system, and they've actually turned their whole system around. And I think that's another element of design that we need to get in touch with the litigation system in this country to support our patients, not reduce necessarily all the incomes of the lawyers, but there is a battle to be won there in terms of how we are literally wasting millions of pounds. So for me, that's that element. And if there's one hospital you could look at, it's Bellin system, who have looked to identify that it's the healthy workplace that really demonstrates how you can improve quality and reduce costs. And that's by investing in the staff of the hospital and not necessarily in a lot of the other elements that we keep on trolling out and making the same mistakes on. So that's enough for me, I think, at the moment.
Thank you, Bob.